is scheduled to begin momentarily. Until that time, your lines will again be placed on music hold. Thank you for your patience.
And welcome to the Comprehensive Primary Care Plus webcast. All lines have been placed on mute to prevent any background noise. Please note that today's webcast is being recorded. During the presentation, we'll have a question and answer session. You can send in text questions at any time. Click the green Q&A icon on the lower left-hand corner of your screen, type your question in the open area, and click Submit. If you would like to view the presentation in a full screen view, click the full screen button in the lower right-hand corner of your screen. Press the Escape key on your keyboard to return to your original view. For optimal viewing and participation, please disable your pop-up blockers. And finally, should you need technical assistance as a best practice, we suggest that you first refresh your browser. If that does not resolve the issue, please click on the Support option in the upper right-hand corner of your screen for online troubleshooting. It is now my pleasure to turn today's program over to Dr. Laura Sessoms. Dr. Sessoms, you may begin.
Thank you. And welcome everyone to what is the second. I'm Dr. Laura Sessoms, the Director of the Division of Advanced Primary Care here at the Innovation Center, and I'm joined by Sarah McHugh, who is the team lead for CPC Plus. And we, along with the whole team, are just so excited by the interest in the model and to be able to talk in detail with you about it. Today we're going to walk through at a high level aspects of the model that are relevant specifically to payers and to vendors, and then finally to primary care practices. And of course the parts that are specifically relevant to primary care practices should be relevant to everyone. I want to talk about the three main goals that underlie CPC Plus. And as a practicing general internist, I'm fully aware of the myriad problems in primary care, both in terms of patient outcomes and the burdens practices face in improving those outcomes. And what we're trying to do here is fix those problems, and by doing so to achieve the primary care model goals of better care, smarter spending, and healthier people. So to accomplish that, we want to advance care delivery and payment to allow practices to provide more comprehensive care that meets the needs of all of their patients, particularly those with complex needs. We know that practices have varying levels of experience with readiness to jump into the care delivery redesign we envision. Hence, we're offering two tracks with different eligibility and care delivery redesign requirements. We also are very aware that transformation takes time. Hence, CPC Plus will last for 5 years, from 2017 when it begins through 2021. And it will also be quite broad in reach, up to 20 regions around the country. Importantly, CPC Plus is a whole population level transformation. We know that a Medicare model alone cannot achieve that, as primary care practices serve patients whose health care is paid for by many different insurers. To include a particular region in CPC Plus will require a density of payers interested in partnering with us in the model. So CPC Plus will be a multi-payer model to ensure that practices have sufficient financial resources from the majority of the payers who insure the patients they serve to support the staffing and other resources required to deliver the care we will expect in CPC Plus. As you can see here on the slide, the myriad payers that we hope to engage as payer partners in CPC Plus. We learned in our current primary care transformation model, the Comprehensive Primary Care Initiative, when payers work together to support primary care practices, the practices are able to work towards the goal we all support of healthier people, better care, and smarter spending. We've seen in CPC that working together, the payers are able to achieve better outcomes than any one payer can achieve working alone. And we are continuing this aligned model in CPC Plus. Note that the application period for payers began on Friday, April 15th, and runs through June 1st. So what does it mean for a payer to partner with CMS and CPC Plus? What does our requested alignment look like? Well, we're looking for payers who are willing to align their payment structure, quality metrics, and data sharing with those of Medicare to meet the goals of CPC Plus. And by align, I don't mean that these elements must be identical. Rather, they are aligned in principle and goal. So for payment, we seek alignment in the 3 features of CPC Plus payment. Those 3 things are, first, a care management fee or similar enhanced payment for each track in CPC Plus. Then number 2, this applies only to track 2, at least a partial alternative to fee-for-service that can help practices deliver clinical care more efficiently and in a more patient-centered manner that does not necessarily require an office visit. 3, an incentive payment in each track that's based on performance outcomes at that practice. And then we also want to align quality and patient experience measures with Medicare fee-for-service and other payers in a given region. And then practice and member-level cost and utilization data, we want engaged payers to provide practices at regular intervals for all practices. Once payers have applied to the model and we've selected the up to 20 regions for the model, we will then solicit the primary care practices. After the announcement of the regions, the practice application period will begin on July 15th and will continue through the end of the summer. Accepted practices will be announced in October. CPC Plus will offer practices many benefits: the ability to provide enhanced care for patients and improve their outcomes, engagement in a robust learning community of other practices working hard on care delivery redesign, and involvement with payers providing aligned payment, quality measurement, and payer data sharing. In Track 1, we'll have up to 2,500 primary care practices, and this is for practices ready to build the capabilities to deliver comprehensive primary care. In Track 2, we will also have up to 2,500 primary care practices, and Track 2 is appropriate for those practices poised to increase the comprehensiveness of care using enhanced health IT, working on the care of patients with complex needs, and assessing patients' psychosocial needs and inventorying resources and supports to help meet those needs. To participate in CPC Plus, practices must enter the model with some experience in care delivery redesign beyond that seen in traditional primary care. This experience will be critical to ensuring that practices have the capability to do the work of the model and achieve its aims. We expect that practices applying to either of the 2 tracks will have some experience with improving patient access to care, with defining their patient population as a whole, and quality improvement experience. As I mentioned, the application period will run from July 15th through September 1st, and we will announce the regions immediately prior to the start of the practice application period. Practices applying to each track must demonstrate the use of certified EHR technology. They must have sufficient payer involvement in the model to cover the majority of their practice population. And their existing care delivery activities must include assigning patients to a provider panel, providing 24/7 access for patients to reach the practice and for the practice to have access to the electronic record during those contacts, as well as supporting quality improvement activities. In addition, though, in Track 2, practices must also develop and record care plans, follow up with patients after emergency department discharge or hospital discharge, and have implement a process to link patients to community-based resources. In addition to these care delivery requirements, Track 2 practices must apply with a letter of support from a health IT vendor or vendors that outlines the vendor's commitment to support the practice in optimizing health IT. Now, I want to take a moment to discuss the involvement of health IT vendors in CPC Plus, because it's a new concept and not one that we have done previously, so it will be new to many of you. As I mentioned, all practices in CPC Plus must use certified health IT. Yet we know that health IT that supports the care of a population of patients by a care team is both critical to the efficient delivery of advanced primary care and is also not commonly available. In Track 2, we're going to focus on practices engaging directly with their health IT vendors to ensure that those practices obtain this necessary infrastructure. Operationally, Track 2 practices will apply to CPC Plus with a letter of support from their vendors to facilitate the use of emerging health IT capabilities. After the practices are selected, the health IT vendors for participating practices will sign a simple MOU with CMS. So I want to go into a few more details about the vendor engagement in CPC Plus. As a vendor partner, vendors will work with their Track 2 practices on a core set of advanced capabilities for health IT. CMS has and will continue to collaborate with the Office of the National Coordinator on this really critical aspect of CPC Plus. We certainly anticipate, with the help of CMS to facilitate the relationship, that the vendors will work closely with the practices who are themselves working to deliver advanced primary care and are using the vendor's technology. In addition, the HIT vendor partners, through their engagement with the payer partners and the participating practices in the learning and other model activities in CPC Plus, are going to have an insider's view of the work the practices are doing and the goals they are working towards. We hope that this close collaboration between vendors and advanced practices will result in the development of efficient and effective IT platforms that facilitate high-quality, team-based, population-focused care delivery. If you are an interested vendor, here is what we're going to ask of you, which is that if you're interested in partnering with CPC Plus practices, please send now the information listed on the slide with your contact information to our email address, cpcplus@cms.hhs.gov. We want this information now to facilitate the practices obtaining the necessary letter of support from theirs or an interested HIT vendor. Additional vendor information is available in Appendix C of the Request for Applications, or RFA, that's available on the CPC website, CPC Plus website now. And note that we are hosting a vendor webinar later this week, and details about that are available on the website. I've talked now about how payers and vendors will partner with Medicare and CPC Plus. Let's turn now to the care delivery work of the model and talk about what the primary care practices participating in the model will actually do. We've organized the work of care delivery into 5 functions or corridors of action. And so what we mean by function is truly a corridor of action, and it's what leads the practices into a capability to deliver comprehensive primary care. There are 5 functions, which you can see here: access and continuity, care management, patient and caregiver engagement, planned care and population health, comprehensiveness and coordination. You may be asking yourself, how can there be just these 5 functions and 2 tracks? What's the difference? And the basic idea here is that Track 2 practices will work more deeply into these functions, but practices in both tracks will be working on improving their ability to deliver each of these 5 functions of primary care. I'm now going to take a moment to go in a bit more detail into what the work in these 5 functions will look like. The CPC Plus care delivery requirements are intended to provide a framework for practices to deepen their capabilities throughout the 5-year model. And these incremental requirements are used to guide practices through the comprehensive primary care functions, and they're markers for regular, measurable progress towards the CPC Plus model aims. Note that the Track 2 requirements are inclusive of and build upon Track 1. Track 2 will include additional requirements that will aid practices in increasing the depth, breadth, and scope of care offered, with a particular focus on patients with complex needs. As practices become more familiar with the initial stages of the work and gain expertise, they will be ready to refine their work and will see opportunities to continue to improve the care of and outcome for their own populations of patients. As I go through the examples of these 5 functions, starting with the first 3 shown on this slide, please note that these are examples and they're going to give you a flavor for the care delivery work we'll expect. And the final care delivery requirements will be available on the CPC Plus website soon, maybe as soon as next week. So starting first with access and continuity, we know that effective primary care is built on a trusting and ongoing relationship between patients, caregivers, and the primary care team. Multiple points of access to the primary care team enhance that relationship and increase the likelihood that the patient will get the right care at the right time, potentially avoiding, of course, costly urgent and emergent care, one of the major goals of this model. You can see here on the slide some of the different options that practices may have or in which they may engage to increase patients' access and continuity. For care management, this is for high-risk, high-need patients, and it's a hallmark of comprehensive primary care. Practices will identify patients for care management in 2 ways. One, they'll systematically risk stratify their impaneled or assigned population so they can identify the high-risk patients most likely to benefit from ongoing longitudinal care management. And then next, they will identify patients based on event triggers, such as a transition of care or a new diagnosis of a major illness. And for that, they will provide short-term episodic care management regardless of overall risk status. Practices will provide both of these types of care management, targeting the care management to best improve the outcomes for these identified patients. The practices will guide their care management efforts by analyzing internal and payer data and by using care plans focused on goals and strategies that are congruent with patient choices and values. For comprehensiveness and coordination, our function 3, in the primary care setting, this refers to the aim of practices meeting the majority of its patients' population's medical, behavioral, and psychosocial needs in pursuit of each patient's health goals. Comprehensiveness builds on the element of relationship that I talked about with access and continuity, and that is at the heart of effective primary care. This work will involve building capability within the practice to meet some of those needs and building strong and coordinated referral networks within the medical neighborhood and with community-based services to ensure that other needs are met. Turning to function 4, which is patient and caregiver engagement, we also know that optimal care and health outcomes require strong patient and caregiver engagement in the management of their own care, but also in the design and improvement of care delivery. We will require practices to organize a Patient and Family Advisory Council, or PFAC, to help them understand the perspective of patients and caregivers on the organization and delivery of care. Practices will use the recommendations from the PFAC to help them improve their care and its patient-centeredness. And then finally, planned care and population health, the 5th function. Practices will organize their care to meet the needs of the population of patients they serve. So they'll use team-based care, and using that will offer proactive, timely, preventative care and consistent evidence-based management of chronic conditions. Using evidence-based protocols in team-based care and identification of care gaps at the population level, as well as measure and act on the quality of care at both the practice and panel level. I'll bet this seems like a lot of work that practices are going to be doing on care delivery, and we know that it is. We think that these requirements are all critical to achieving the aims of the model. We also know that this will require financial resources to support the work. And I'm going to let Sarah McHugh talk now about the payment structure of the model.
Thanks, Laura. So with that care delivery model in mind, we designed the CPC Plus payment model to support and incent the sort of comprehensive, patient-centered primary care we think clinicians want to deliver and patients deserve to receive. The payment design has 3 components, and I'll do a high-level overview here and then talk about each of them in turn. The first component is a care management fee. This is a prospective, risk-based payment meant to support the hiring and work related to care management and practice changes. It is calculated per beneficiary per month and is higher in Track 2 than Track 1 given the greater amount of work expected of these practices. The second component is the performance-based incentive payment, which is also prospectively paid. This payment is meant to focus practices on clinical quality, patient experience, and utilization metrics. The third component is in Track 2 only, and it is a departure from fee-for-service towards a hybrid payment that is a mix of fee-for-service and what we're calling a comprehensive primary care payment, or CPCP. This innovative payment will offer practices greater flexibility in how they deliver clinical care. Overall, again, we're asking a lot of practices in terms of care delivery, and this payment model is designed to support and encourage that work. As outlined in the Payer Memorandum of Understanding, we expect payer alignment to these payment goals and general framework, but don't expect an identical payment model. So now we'll go into a little more detail on the care management fees. As everyone knows, some patients' chronic conditions require care management, and others have episodic need for care coordination. And either way, it can translate into a significant work for practices to coordinate patient care. And we expect this care management fee to support these sorts of wraparound services. Again, the care management fee is a non-visit-based prospective payment. It is paid to practices for beneficiaries that Medicare fee-for-service beneficiaries that are attributed to them. And these beneficiaries will have no cost sharing of the care management fee. And we attribute patients and determine the risk tiers for payment purposes. And in Track 1, there are 4 risk tiers, and in Track 2, there are 5 risk tiers. Again, payments are higher in Track 2 across the tiers because of the increased work expected of these practices. The payments are calculated per beneficiary per month and average $15 PBPM for Track 1 and $28 PBPM for Track 2. The $28 average includes the top $100 PBPM tier for the patients with the highest risk and certain dementia diagnoses. Payer alignment on this non-visit-based financial support is expected to be similar, but again, does not need to be identical. Payers can use their own attribution and payment per tier. Practices will use the care management fees from both CMS and other payers to direct care management to patients based on clinical need and patient preference. Now let's move to the second element of the payment design, the performance-based incentive payment. This payment is based on quality and utilization, and in an unusual twist, we are prepaying it. How much of the payment practices ultimately keep is based on their performance on utilization and quality metrics. Again, it's broken into 2 components, one for quality and one for utilization. And as you can see, unlike the current CPC model and ACO models, there is no payment for shared savings. This incentive payment is in lieu of shared savings, although it is a proxy for total cost of care, but one that is measurable at the practice level. As a result of this similar incentive structure, we do not allow for primary care practices to be in a shared savings model like an ACO. Again, partner payer alignment on this element does not mean that they must offer an identical design, but that they too must employ a payment design that focuses practices on quality, utilization, and/or total cost of care. So as we just discussed, the incentive payment is split into two pieces, quality and utilization. So let's start with quality, which is the first row. Quality measures include both electronic clinical quality measures and patient experience measures. Practices' performance on these combine to a score that determines their eligibility for the quality component of the performance-based incentive payment. ECQMs, or electronic clinical quality measures, that are included in the EHR and are based on clinical care delivered at the point of care in practices. They are stored in the EHR and are not claims-based. CMS will also use the CAHPS Patient Experience Survey, and both ECQMs and the survey are practice-wide total population measures. The other component of the incentive payment is based upon utilization, specifically hospitalizations and emergency department visits. These are claims-based measures. Performance on these measures compute to a score on the utilization component of the incentive payment. Practices' combined performance on these components determine whether they may keep all, some, or none of the performance-based incentive payment. And we hope will focus their work on aspects that improve quality and patient experience of care and reduce unnecessary utilization of health services. So I talked on the last slide about ECQMs, and this table is a comprehensive list of measures from which practices will choose to report a subset. Please refer to Appendix D of the RFA to take a closer look at this list, which will be finalized later this year. It will encompass the 5 domains of clinical process and effectiveness, patient safety, population and public health, efficient use of healthcare resources, and care coordination. Now I'll provide an overview of the third element of the payment design, the hybrid payment, which again applies to Track 2 only. This payment design will support greater flexibility in the delivery of primary care, and we expect this will be particularly helpful for the provision of care to patients with complex needs. Practices will work towards one of 2 hybrid payment options, both around 50-50, which means practices will get around half of their expected fee-for-service up front, and their subsequent fee-for-service billings will be reduced by the amount prepaid. So how will we execute on this payment design? First, CMS will look at practices' historical evaluation and management billings for attributed beneficiaries. Then we will inflate the expectation slightly to account for the increased comprehensiveness Track 2 practices will deliver. Comprehensiveness of care practices will deliver. Practices will choose from a menu of 4 hybrid payment options. The 2 ultimate options are pictured here, which are 40% CPCP with a 60% fee-for-service, or a 65% CPCP and a 35% fee-for-service. Practices will receive their CP amount up front, and then when a patient comes into the office for an evaluation and management service, the payment to the practices will be reduced by the amount prepaid. So if a practice chose the 40-60 hybrid payment, the practice would receive a CPCP of 40%, and their fee-for-service will be paid at 60% of the normal amount. Again, payer alignment to this payment design element is expected by the end of performance year 1, but it does not need to match the CPCP design exactly, but we expect it would include a departure from fee-for-service. Data feedback is a critical component to much of the care delivery work and to making good use of the payment model. Medicare and partner payers will align their efforts to deliver actionable and timely data to practices at regular intervals. This data will include patient-level cost and utilization information that we expect will empower practices to make the changes and to know whether those changes are working. The data will help practices achieve the goals that result in better care for patients. So we realize practice transformation is fundamental. It's not a quick fix. As such, the CPC Plus learning system will be robust. Practices, as well as payer and vendor partners, will all participate together to support and track the changes practices are making in delivery and payment. The learning system will adapt to stakeholder needs across a couple core platforms. One is an online practice portal where practices will report on their progress on the care delivery redesign. Learning faculty can target learning exercises based on the gaps and challenges that arise and are evident in these reports. Another platform is CPC Connect, which is a web-based platform for all stakeholders to share ideas, best practices, and resources. Think of it as a Facebook for primary care transformation. Lastly, the learning communities will have numerous webinars, learning faculty coaching, and in-person meetings. And these communities will promote collaboration and engagement across regions and tracks, as well as coordinating nationally. So you can see on this slide the CPC Plus Logic Model or driver diagram. It encapsulates all of the work practices are doing for patients and caregivers. The 5 primary care functions that practices deliver are highlighted in the top half of the driver diagram in blue. And this work is supported by the other 3 main elements we discussed, which are payment, health information technology, and use of data. This practice transformation is supported by the multi-payer design, which is indicated here by the purple ring around the outside. And this signifies the alignment of payment to practices, the data sharing, and quality reporting. So that covers the content overview for CPC Plus. So let's look quickly at the timeline. So now through June 1st, CMS is accepting payer proposals. The fillable PDF is available on the CPC Plus website. Review of these proposals will help us determine in what regions there's sufficient payer interest to offer the model. We expect to announce the regions on July 15th, and at that time the practice application will be open for a month and a half, closing September 1st. You can see a draft of the practice application in Appendix B of the RFA. And this timeline will allow practices to get on board, will allow us to review applications, select practices, and have them on board in October so that the model can officially launch in January 2017. So again, please look to our website. We're trying to put everything up there as soon as possible. These slides will be available shortly. Right now, the request for applications, or RFA, is on there. The frequently asked questions, the fact sheet, the payer memorandum of understanding. Again, the slides and more FAQs will be up soon. We also are hosting more webinars. As Laura mentioned, the HIT webinar is on Thursday, and more overview webinars, payer-focused webinars, and HIT webinars will be offered. And you can, again, review our website for more information, and please direct any questions to our email inbox, cpcplus@cms.hhs.gov. So I'll stop now, and we can do Q&A.
Thanks. That's great, Sarah. We've already gotten a number of questions, so we'll just launch in and try to answer them. I'm looking here at a number of them that relate to the regions and how will the regions be selected. Regions will be selected based on payer interest, and we don't have a minimum threshold per se to have number of payers to choose a region. What we're looking for is sufficient density of payer interest so that when practices from a region later apply, they will be able to have the majority of their patient population covered by payers who are participating in CPC Plus. The regions can be either a market region or a statewide region, and it depends on the reach of the payers that apply. So in the current CPC initiative, we have some of both, and it's just based on the market reach of the particular payers that apply. There is one further question on this, on the why are SIM and MAPCP states preferred. SIM is the State Innovation Model, and MAPCP is the Medicare Advanced Primary Care Practice Demonstration, and they are given a preference if their state Medicaid is engaged. In large measure because of the resources that CMS and Medicare have already put into those regions through those existing projects.
We had a few questions about the taxpayer identification number and the definition of a practice. So what constitutes a practice? And for CPC Plus, it is a TIN NPI practice site location combination. So that's taxpayer identification number, national provider identifier, and the physical address. And another question was, if multiple practices share a TIN, do all need to participate? And the answer is no. It is just the TIN, NPI, and practice site location. We also had some questions of whether practices can move from track 1 to track 2, and the answer is no. If you start in track 1, you're in track 1 for the duration of the model, and the same for track 2.
I have some questions here about requirements to be recognized as a PCMH. And no, there is no current requirement. There is no requirement to come in with PCMH recognition externally. We do know, though, that some of the requirements that go along with these various PCMH recognition programs might have been useful to practices in developing the eligibility to participate in CPC Plus. There is, if you were to do a crosswalk of our requirements and some of the other certification requirements for PCMH, there are overlaps and similarities that you would note. A question, can nurse practitioner-led practices participate? And absolutely they may. And if you are a multi-specialty primary care practice, the participation in CPC Plus would be limited to those practicing primary care, which would include internal medicine, family practice, geriatrics, and include nurse practitioners and physician's assistants who are in that work.
We had a few questions about whether CPC Plus fulfills the intent of MACRA under the alternative payment model and how CPC Plus will work with MIPS. And we encourage you to stay tuned for the Notice of Proposed Rulemaking on the alternative payment model regulation. At this time, it is not determined, but we expect that rule shortly, and more information will be available there as to how CPC Plus is affected.
More questions about providers in a practice. Do all the providers in a practice need to participate in CPC Plus? And how about in the same track? We view CPC Plus as a practice-level transformation. So all primary care practitioners in the practice would need to participate in the same model. Specialists and subspecialists in the practice obviously cannot and would not participate in CPC Plus.
We had a few questions about the care management fee. Is the care management fee paid up front? And yes, it is paid up front. Another, how are risk tiers determined for care management fees? The slide that I went through outlines how Medicare fee-for-service is determining risk tiers. We are using a risk score based on the hierarchical condition category, or HCC, but again, other payers can use their own risk determination.
Some questions here about payers. What are some of the incentives for payers to participate, and how can we encourage payers to participate? So again, based in large measure on what we know about the resources that primary care practices require to redesign their care delivery and engage in advanced primary care, we know that it takes resources that are insufficient when coming from one payer only. And when payers work together to align in payment and provide the necessary additional resources, and also align to provide both cost and utilization data to practices, and as well as align on quality metrics so that practices can focus their efforts more clearly rather than be overwhelmed by many competing measures, practices are able to move much further ahead, and the outcomes for patients are much improved. So payers stand to each improve with the care of their individual population when practices are given the resources from aligned payers to transform in a direct way.
Had a question about how many practices per region. And again, we are going to solicit payer interest first, and we are expecting to accommodate up to 20 regions, and we can accommodate up to 5,000 practices, about half attributed to each track. But again, we'll have to figure out how many regions have sufficient payer interest before we can determine the exact number of practices per region.
If your practice is in a region where commercial payers don't show enough interest to set up a formal program, are you able to participate in a Medicare Only population? So what this CPC Plus will require is that once we have the region selected and practices are applying, that there is sufficient payer coverage of the population from that practice that a majority of the practice's patient population are covered by engaged payers. So if a practice has a substantial majority of Medicare fee-for-service patients, then that is feasible that it would be just covered by Medicare. But I think in general, it's going to take for practices a number of payers that will want to be engaged. And a similar question is, will CPC Plus cover patient populations both under and over 65 years old? And the answer to that is absolutely yes. While Medicare fee-for-service substantially only covers over 65, not entirely, but substantially, commercial payers and others, including Medicaid, will be covering a wide range of patient ages.
Had a few questions about attribution. How will you match patients with primary care physicians? Is it claims-based? And yes, it is claims-based. It's based on the plurality of their primary care claims over the past 2 years. More detail is available in an appendix of the request for application. Another question, can you talk about how other payers will do attribution? And again, we are not prescriptive as to how other payers do attribution. Some more payment questions. Will new codes such as CCM and TCM no longer be allowed for use in CPC Plus attributed patients? The CCM is overall has some significant overlap with the CPC Plus Care Management Fee. So CPC Plus practices will not be allowed to bill the CCM for attributed Medicare fee-for-service beneficiaries. The TCM, though, they will be allowed to bill. And another question is, in Track 2, is the CPCP a payment given to practices in addition to the care management fee and incentive payments? And yes, it is. So for Track 1, they only get the care management fee and incentive payments, but in Track 2, all 3 payment elements apply.
Another question quite similar to that on the chronic care management code payments. That practices have to bill for that code. Do the PBPM payments come automatically to the practice, or do they need to perform any specific activity? So to be clear, the care management fee will be paid prospectively in advance for patients attributed to that practice. The practice, in turn, will be required to perform the care delivery requirements of the model. And that is the specific activities that the payment will be covering.
And a question, is there a patient copay? And there is no copay on the care management fee, but when patients come into the practice for evaluation and management or other services, they will pay their copay as they do normally, and there's also no copay on the performance-based incentive payment.
Or the CPCP.
Or the CPCP, right.
I have a question here about overlap with TCPI or the Transforming Clinical Practice Initiative, and why can't practices participate in learning? And the reason is because there's a separate learning community as a part of CPC Plus. And while we are closely tied with TCPI, TCPI will be focusing on practices that are not engaged in alternative payment models. And once you a practice enters a model like CPC Plus, the learning support from TCPI ends and the learning support from CPC Plus begins.
Had another question about if you belong to an MSSP ACO, can you apply for CPC Plus, and if accepted, drop out of MSSP to begin CPC on 1/1/17? And the answer is yes. You can apply when you're still in another program, but you cannot simultaneously participate in both programs.
And how does CMMI anticipate CPC Plus coexisting with similar CMS, CMMI, Affordable Care Act initiatives such as the SIM or State Innovation Model, Section 2703, Health Homes, and dual eligible related programs? I think there's a bunch of information in the request for application about overlaps. Specifically talking about the State Innovation Model, we absolutely expect that practices will be participating in a number of State Innovation Model states and will be involved in both programs.
Had some questions about the payer partners. Does the health plan have to have all products participating in CPC Plus? Can they simply enroll their MA but not commercial and Medicaid? And it is up to the payer partners about which lines of business they propose to partner with. And are MA plans supposed to apply this to their MA members as well as original Medicare, or are they contracting to cover original Medicare only?
I think what that question is getting to is that MA plans would be applying for their MA members. And we, as Medicare fee-for-service at CMS, are covering Medicare fee-for-service patients or beneficiaries.
And then will CPC Plus include Medicaid bennies? And again, Medicaid is considered a partner payer, and if a state Medicaid agency or Medicaid managed care plans choose to partner with Medicare fee-for-service on this initiative, Medicaid bennies will be included.
A question here about technical assistance for participating practices. We fully recognize that this level of primary care transformation requires a robust learning community. And we anticipate having a national and regional learning community for practices. We also have a practice peer-to-peer sharing platform called CPC Connect, where practices will be able to engage with each other to help share best practices. We know that practices will want to meet face-to-face as well as virtually in other learning sessions. So there will be substantial, we call it learning support for practices.
Had a question about whether current CPC regions will receive preference, and yes, they will. If there's more than 20 eligible regions, CPC regions, as well as how Laura said about SIM and MAPCP regions with their state Medicaid agencies, will receive preference.
We've gotten a number of questions about pediatricians, and can pediatricians participate? So there is a requirement for a limited number of Medicare fee-for-service patients, and the number is approximately 100 Medicare fee-for-service patients. And if a pediatrician has that, or practice has that number of patients, as well as others covered by engaged commercial or Medicaid payers, then they can participate.
Had a question of whether you can apply to both tracks, and we encourage application to only one track, though if you apply, say, for track 2 but are deemed eligible for track 1, CMS does reserve the right to grant you acceptance to track 1. That's for practices. For payer alignment, we expect alignment on both tracks payment models, and details for that are available in the Memorandum of Understanding that is now on the website.
I have a question about where can we go to view the results of CPC that ends in 2016. CPC has its own website, and if you just Google CPC CMS, you will find it, and the results to date, which is almost halfway through the initiative, so only the first couple of years are available, but those are there on the website.
I had a question, will practices have to re-stratify their patients using HCC? And no, this again is what Medicare Fee-for-Service is using to score the risk for Medicare Fee-for-Service beneficiaries, but other payers can use other risk stratification tools, and practices can either adopt these or use their own. We are not prescriptive in that. And again, another one is the CMS in addition to the CPCP, and yes, it is a separate payment element in addition to the CPCP.
So a couple of questions about referrals and care coordination. One about how might community mental health centers and local mental health authorities engage with CPC Plus practices to support total care of the patient, and to what extent is behavioral health addressed? The care delivery requirements that will be posted shortly on the website will clarify this, but behavioral health is an integral part of the model, particularly in Track 2, and community mental health centers and other mental health providers and resources will be able to engage, or the practices will be able to reach out and link with those resources in the community to help assure better care of their patients' mental health needs. And then another one about care coordination, is this more than just specialist referrals? And absolutely it is. It can be, it's robust agreements with specialists about how practices will be cared for, either through care compacts or care coordination agreements, and can involve all sorts of decisions about how to co-manage or allow for principal care of patients between primary care and specialty care.
Had a question of whether practices need EMR to participate, and yes, there are requirements for electronic medical records. You can read more about the health IT component of the model in Appendix C of the request for application that's available online. Another question was, who pays the HIT vendors, practices or CMS? And practices will pay the HIT vendors. CMS will sign a memorandum of understanding with vendors, but it does not include payment.
Question here about, do payers or CMS select practices? CMS selects the practices. And will solo practitioners be allowed to participate? Absolutely they will. Another question here is, if you have been in CPC prior, will you be required to be in Track 2? The answer to that is no. And question on a different tack, will there be changes in evaluation and management documentation for office visits? The direct answer to that question is no. However, in Track 2, the evaluation and management codes for established and new patients and prolonged visits will be the aspects that are rolled up into the so-called CPCP and paid prospectively, or at least a percentage of that will be paid prospectively, and the part that is paid prospectively will not require traditional E&M documentation.
Had a question of whether multiple TINs could apply jointly to the model. And this is a practice level intervention, and the practice application will be TIN NPI practice site specific. So multiple practices from a TIN are welcome to apply, but the application will be practice specific.
A question about how often do we have to submit electronic clinical quality measures and CAHPS data? The CAHPS data we do ourselves for the practice population. We take a sample of each practice's total population and field that survey annually. So the practices don't submit the data. Instead, they submit their patient roster to us, and then we take a sampling and do the CAHPS surveys. For ECQMs, practices are required to report their ECQMs annually. There's another question about, can we apply as an IPA? Practices will have to apply individually because we believe this is a practice level transformation. And same answer to another question, if a practice has multiple locations, do you submit an application for each location or the practice? So for CPC Plus terms, the practice is a bricks and mortar location, and each location needs to submit an application, but there will be an opportunity on the application to indicate affiliation, both with an IPA or other sites.
Can a practice be enrolled in an AHC grant, which is Accountable Health Communities, and CPC Plus? And yes, a practice can be in both.
So how do you define readiness for participation? As we indicated on the slides, and again, those will be available on the website shortly, a practice that has to have sufficient coverage by participating payers, has to be using certified EHR technology, and have some experience with practice transformation. That experience can be more modest for those applying to Track 1 and must be a little deeper for those applying to Track 2. Track 2 practices also have to apply with a letter of support from their HIT vendor.
Probably our last question, do state Medicaid programs have the option to participate as payers? Yes, we encourage state Medicaid agencies to apply or to respond with payer proposals.
So thank you very much for joining us, and stay tuned to the website for more information as it becomes available. Thank you.
Ladies and gentlemen, thank you for participating in today's webcast. This concludes the program. You may now disconnect.